I'm Dr. Nicholas Colivas. I'm a professor of clinical orthopedic surgery at the University of California in San Francisco. Today I'm going to present a case of a medial meniscus root tear. This case will illustrate our approach to these types of tears and what we do to return patients to full function. Our case today is a 63-year-old female who is quite active, who loves to garden, she walks, she plays tennis. And about 6 weeks before she came to us, she had had a mild twisting injury to the right knee, which resulted in initially quite severe pain, a significant limp, difficulty walking, but over time has improved somewhat, and now on presentation is really more of a vague low-grade medial to posterior pain. Her examination showed a good range of motion. Many of her meniscus tests were positive. Her knee was stable to testing, and her x-rays were rather unremarkable, which is fairly typical for this type of situation. And these are the x-rays here, and you can see some mild medial joint space narrowing, but really otherwise a knee in pretty good shape. We obtained an MRI to evaluate further because of our concern for a meniscus tear. And on MRI, the important findings are shown here. This is the coronal at the level of the medial meniscus root. You can see a separation there, which equals a tear. There's also some extrusion of the meniscus. At about the mid-body picture here, you can see that extrusion is pretty significant. And on the sagittal, we have this view cutting through where you should see the root, and all you see is this sort of high signal change, which we call the ghost sign. Very typical and pathognomonic, in fact, for a meniscus root tear. We always look at the axials because many times, not always, but many times you will get a good view of the tear on the axial, and here's a clear indication of the separation. So this patient was taken to surgery, which is something I think we recommend in the vast majority of cases for a root tear. And this was the findings at the time of surgery. You can see that root is torn posteriorly there, and also typical for this type of situation is some early change on the cartilage surface of the femur, which you can see is not 100% smooth. So we start by debriding this tear and making sure we get a good view of what the tear looks like. Also, we want to test mobility. In the more chronic tears, it's difficult to get these tears to come over and reduce the extrusion again. In the more acute ones, it's usually pretty straightforward. Once we've got a good handle on what we're looking at here, we'll pass some sutures. These are done with any one of the number of different types of suture passing devices now available. We use actually tape, not suture itself. This is 1.3 tape. We think that provides additional strength, and we will always, or almost always at least, use 2 sutures for additional strength. These are placed in a racking suture or a locking or luggage tab type suture configuration. We then drill into the root insertion sites, and then we spend actually a fair bit of time cleaning this site up and preparing it. We feel that getting a really good bony bed is important, so we will use a curette and then a shaver to make sure that we've really exposed an adequate amount of bone for that meniscus to heal back down onto. This can be done with a flip cutter too. We typically just use a curette here and get a nice bleeding bony surface here, like you can see. Once we've done that, we will then actually drill into that bleeding bony site. That is a 4.5 drill. Once we've got that drilled, we will actually shuttle the sutures through those Sutures are then pulled down, and once you, this is the satisfying part of the case, when that pulls that meniscus right back down onto that area which you've prepared, reduces the extrusion and returns that meniscus to its root insertion. We then suture that. We then secure that with a button, and we back that up with an anchor. Our post-op protocol is non-weight bearing for 4 weeks. Then we do allow weight bearing and tolerated in extension for 2 weeks. We do limit post-op flexion to 90 degrees for the first 6 weeks, typically for these type of situations. These are the post-op x-rays. You can clearly see the button that we use to secure the sutures for this transtibial fixation, and we always back this up with an anchor. This patient went on to do very well post-op. She had no significant pain, and at about 6 months was able to return to her full activity level, including her gardening and tennis. Thank you for listening to this presentation of a medial meniscus root tear. Dr. Nicholas Collivas from UCSF. Thank you.